Hello everyone, welcome and thank you for listening. I am Brittany Fauble, a senior clinician at the American Institute of Balance. I also serve as the Institute's Director of Diagnostic Services, overseeing the clinics, our contract services, student programs, and international fellowships, and I'm also a faculty member. Today we are going to discuss the high-frequency headshake, both the seated and the lateral body headshake. Over the years, it has come to our attention that many providers are not utilizing the high-frequency headshake, so today we're going to dive in and show how easy and fast it can be to administer, and briefly touch on interpretation. So, let's get started on how to integrate the high-frequency headshake into your clinical test battery. The high-frequency headshake is a dynamic test that can easily be included into the video nystagmography battery. With the high-frequency headshake, the patient is rapidly exciting the peripheral vestibular systems. Remember, when one system is excited, the contralateral side is inhibited. In the case of a rightward head turn, the right ear is excited and the left is simultaneously inhibited. The opposite is true for a leftward head turn. The high-frequency headshake is rapidly exciting and inhibiting the ears over and over. The bilateral information is then sent to the vestibular nuclei and is held there in the velocity storage so the brain can receive all the information from the equilibrium systems, interpret it, and then decide what to do. Again, in a healthy system, the information received from both sides is equal and all is well. However, in the case of a unilateral dysfunction, there is a mismatch of information coming from the right and the left vestibular systems, and when completing the high-frequency headshake, this can elicit a post-headshake nystagmus. Let's say the patient has a left unilateral vestibular dysfunction. During the headshake, the patient is exciting and inhibiting the inner ears over and over and over, sending more and more information to the vestibular nuclei. However, the signal coming from the left ear will not be as strong. Following the headshake, due to the weakness, there will be a mismatch, where the vestibular nuclei has received more information from the right ear, and there will be a post-headshake nystagmus. In this example, the right ear is the healthy and strong ear. Therefore, the nystagmus will be labeled as right beating, with the slow phase drifting to the left ear and snapping back to the stronger right ear that's giving the vestibular nuclei more information than the left. Let's talk procedure. Remember, any spontaneous or provoked nystagmus that is due to peripheral dysfunction can suppress or fixate, so the high-frequency headshake needs to be completed in the dark with the goggle covered. The VNG goggle also needs to be snug, as the headshake can cause them to loosen and slip, resulting in any light in the room to seep into the goggle, and it may also result in a poor recording. The patient is seated comfortably, looking straight ahead. Before you have the patient start to shake their head back and forth in the horizontal plane, it's important to have them tilt their head down about 30 degrees. This will put the horizontal canals parallel to Mother Earth, allowing for maximum stimulation. The patient then shakes their head for at least 20 seconds at 2 Hz or more. The headshake is not about distance. It is rather about speed. So as long as the patient is turning their head at 2 Hz and evenly to the right and the left to stimulate the ears equally, then they do not need to cover any more than 20 to 30 degrees to the left and the right. Lastly, if the patient would like to complete the active headshake with their eyes closed, that is okay. It is the post-headshake window that is important. About 3 to 5 seconds before they stop shaking their head, have them open their eyes so the camera can capture any post-headshake nystagmus. As you can see in this example, this is a right beating post-headshake nystagmus, which means there's a left unilateral dysfunction. You can see that the nystagmus fatigues and completely dissipates 10 to 20 seconds post-headshake. If the patient's appointment is relatively close to their initial vertiginous attack and they have not begun the compensation process, there may be a spontaneous nystagmus when the patient is covered in the dark or maybe even in a vision-enabled condition prior to the headshake. This test should still be completed, as an enhancement in this nystagmus can occur if it is a peripheral vestibular involvement. Any increase in nystagmus that is 3 degrees per second or more is considered an enhancement and therefore a positive result. Remember, this dynamic test is comparing the input from both ears. As previously stated, in a case of 2 healthy ears, the input from each is equal and therefore will not elicit any post-headshake nystagmus. The same is true for a bilateral peripheral dysfunction. Since both ears are sending the same amount or no information to the vestibular nuclei, then the signals are equal and will not cause a post-headshake nystagmus. This is an example of what the VNG recording would look like for the previous patient. You can see here, prior to the headshake, there's no spontaneous nystagmus. The patient shakes their head for 2 Hz for 20 seconds, and after they stop, you can see a robust right beating nystagmus that suppresses with vision enabled. In this case, a right beat nystagmus is indicative of a left unilateral vestibular dysfunction. Of course, this test should be compared to the patient's history, symptoms, and results from other tests in the battery. One thing to consider is where this test should fall within the patient's appointment and testing battery. As you can see, this is a symptom-provoking test, and those with unilateral vestibular dysfunction will often feel nauseous during and after. So it's important to not start with the high-frequency headshake. If the patient becomes ill right at the start of the appointment, they may not want to continue for a significant period of time, or, in extreme cases, some may not want to continue with testing at all. The VNG test is typically completed after posturography, and the high-frequency headshake within the VNG is completed after ocular motor testing, spontaneous and eccentric gaze testing, and after the rotary chair test if it is available. Alright, moving on to the lateral body high-frequency headshake. This test is completed in the same manner as the seated high-frequency headshake. However, instead of the patient being seated, the headshake is completed in the body left and body right positions. This test is theorized to be more sensitive in identifying unilateral vestibular dysfunction than the seated headshake. Like with the seated headshake, the lateral body headshake will elicit a post-headshake nystagmus that beats towards the stronger, healthier ear in the case of a unilateral vestibular dysfunction. Additionally, the nystagmus will be stronger when the patient is lying on the side of the weak or sick ear. Let's watch a video of the lateral body headshake in action. The patient here is lying on their right side. The goggle is covered and they will shake their head back and forth at 2 Hz for 20 seconds. Post-headshake, you can see a right beating nystagmus. We know this patient has a left unilateral vestibular dysfunction based on this test, his symptoms, his history, and other tests we have completed in the test battery. We would then complete this test in the left body lateral position, and the results will still be a right beating nystagmus, as the unilateral vestibular dysfunction is on the left. However, the strength of the nystagmus would be stronger because the patient would be lying on the involved ear's side. This is an example of what the VNG recording would look like with the raw positional recordeds included. This example is not based on the previously seen patient. It is recommended that the lateral body high-frequency headshake is completed when you are completing positional testing, as the patient is already in the test position. It is very important that horizontal canal BPPV, benign paroxysmal positional vertigo, is ruled out prior to the lateral body headshake, as the patient may become very nauseated and will likely result in emesis. So it is ill-advised to complete the body lateral high-frequency headshake in cases of horizontal canal BPPV. In this example, the H represents the horizontal channel, while the V represents the vertical channel. Just as the post-headshake nystagmus is stronger when the patient is lying on the involved ear side, same is true when completing static positional testing. In this case, there is a right beat nystagmus in supine position, nothing in body right position, and a consistent right beat nystagmus in body left position when compared. So, already the testing is indicating a left unilateral vestibular dysfunction. When we add in the body lateral headshake, you can see that there is no post-headshake nystagmus in body right. However, there is a significant enhanced nystagmus in body left. This is an example of why you should always complete both lateral body positions so you can compare both and so nothing is overlooked. As always, this test should be compared to the patient's history, symptoms, and results from other tests in the battery. That was a little taste of the high-frequency headshake. It is an easy test to administer that offers good diagnostic information. In total, both the seated and body lateral test will add approximately 5 minutes to your current VNG test battery and can give you a wealth of information. As with any test, it's important to cross-compare and correlate with the patient's history, symptoms, and any available head imaging studies. To learn more about its diagnostic utility in both peripheral and central indicators, see more examples, or if you're interested in the vestibular rehabilitation process, please visit our website at www.dizzy.com/workshops. You can also find our research and publications at dizzy.com and more patient case studies in Dr. Gann's blog post. On behalf of the American Institute of Balance, I want to thank you again and wish you a wonderful rest of your day.